Hello, everyone, and welcome to today's program, Clinical Documentation Improvement and Initiatives that Drive Quality Performance and Financial Reimbursement, presented by Cerner and Nuance and hosted by ACDIS. My name is Katie Rushlow, and I'm an editor for CDI for ACDIS and HC Pro, and I'll be your host for today's webcast. Our program will be 60 minutes in length. The first portion of the program is presentation, followed by a question and answer session. Today's program is also being recorded. Before we get started, I'd like to take a moment to review the web conference platform. First, to ensure that you can see all of the content for the event, please maximize your event window. Second, be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Third, at the bottom of your console are multiple widgets you can use. To submit a question, click on the Q&A widget. It may be open already and appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program. Should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. We're very excited to offer you this free educational opportunity by Cerner and Nuance. Now I'd like to introduce today's speaker. Angie Curry joined CoxHealth in 2002 and serves as a corporate CDI manager over 12 clinicians that review 1,500 cases per month for a 2-hospital system in Missouri. Additionally, she is responsible for working closely with physician leadership on education and training around documentation rules and guideline changes. Welcome, Angie.
Thank you, Katie. I'm glad to be presenting today.
We're glad to have you. Finally, before we get started, a copy of today's presentation is available in the Resource List widget, which is located on the lower left area of your screen. As a reminder, this program does offer CCDS credits for the live program only. To obtain these credits, please download the instructions from the Resource List widget. Please note that an on-demand version of this program will be available approximately 1 day after the completion of the event and can be accessed using the same login link that you used for the live program. With that, I'd like to pass over the program to Angie to begin our presentation.
Thanks, Katie. And welcome, everyone. I'm going to talk to you today about CDI initiatives that drive quality performance and financial reimbursement. As Katie told you, my name is Angie Curry, RN BSN CCDS, and I am the corporate manager of the CDI program at CoxHealth Systems. And this is our main facility. This is the Springfield campus. CoxHealth has been in Springfield, Missouri since 1906, very strong roots. Our primary facility is located in Springfield with 500 beds. It is a level 1 trauma and stroke center. We also have a tertiary facility in Branson, Missouri, which most of you may be familiar with from all the advertising they do to get people to come visit. So we're going to talk to you about the programs that we have at both of these facilities. Of course, I can't talk to you about today's workflow without letting you know where we've been. So the program was started in 2003. At that time, of course, it was a paper query system. They used priced Waterhouse-Cooper and a standalone 3M encoder. There were 3 full-time RNs. They only looked at new admissions, no follow-ups. They had a manual process of reconciliation based on just their queries. And at that time, the department actually reported to case management, and they were limited to Medicare reviews. In 2009 was the first software program that the CDI nurses had, and it was ESON. I know that's something that the case management staff here at CoxHealth like and still use. They continued with 3 full-time FTEs. The ESON program did allow them, however, to search for those diagnoses and possible ICD codes. However, the query was still not part of the permanent medical record, and they were still limited in the patients that they could review. The big change came in 2011 when the department was actually transferred to be led by HIM. At that time, they increased the staff to 8 FTEs and contracted with J.A. Thomas utilizing a standalone software called The Guide. This was the first software that the CDI nurses had used, so they were thrilled to have something that was truly specific to CDI. The guide in 2011 allowed the queries to become a permanent part of the medical record. We used the Cerner Message Center. The data was able to be gathered and reported out with the monthly JADA data. There were two things that were important with it being part of the medical record. Number one, the physicians were more aware that their responses would be saved in the patient's medical record. And number two, it allowed us to have better data around timing. How long did it take them to answer the query? Not only did they answer it, but what was the time frame there? There was an increase in the overall CMI at the Springfield campus related to the increased reviews and queries. However, for the CDI nurses, it was still a two-system workflow. They were logging in and out of the embedded guide and then logging in and out of the electronic medical record to try to make a complete worksheet. When we had the opportunity to participate in the beta test site for embedded CDI, I was all about it. I had seen some of the demos that they had. There were some great additions to the product. The biggest thing was it does reside within the electronic medical record, so the staff was no longer having to log in and out of two different platforms. The second was it has a grouper. Now, I don't know if other CDI programs have struggled with not having a grouper. So for me, that was a big piece of it, and I will talk a little bit more about that later. Utilizing the embedded guide did allow inclusion of all of our primary DRG payers. We were also able to expand to all inpatient nursing units except for pediatrics and psychiatric. And now we have a polling question. Katie?
Okay, everyone. So we do have our first polling question. In a moment, you'll see the question and possible answers appear on your screen. Please select the appropriate answer using the radio buttons on the left side, then hit the Submit button at the bottom of the polling window. You may have to scroll down to see the fifth answer option and the Submit button. You may select your answer at any time while I'm reading the question. Your results will appear along with those of the entire audience. Now for the question, do you have a CDI program, and if so, do you use software? Please select one of the 5 answers and hit the Submit button at the bottom of the polling window. No, my organization does not have a CDI program today. No, my organization does not have a CDI program, but we are considering funding for resources and technology. Yes, my organization has a CDI program, and we use software. Yes, my organization has a CDI program, but we use paper-based queries, and I don't know. Again, the 5 answers are no, my organization does not have a CDI program today. No, my organization does not have a CDI program, but we are considering funding for resources and technology. Yes, my organization has a CDI program and we use software. Yes, my organization has a program, but we use paper-based queries, and I don't know. It looks like we're starting to have some answers come in, so I'll pass it on to Angie to comment on the results. Angie, can you see the results?
I can, and I'm so glad to see that most people listening on the call today do have a program and they are using software. One of the reasons that we decided to ask this question was when we had done previous surveys, we had found that there were a lot of CDI programs that were not using software, and that is one of the things that I want you all to see today, that the software is really worth the money and the benefit you can provide to your facility. So let's go on. I do see the second highest is my organization has a CDI program, but we're using paper-based queries. And I can tell you the paper-based queries a lot of times end up in the trash can. So that is a huge reason to move to the software in itself. I'm going to go ahead now with the next slide and tell you a little bit more about our story. So the modern medical team. As you can see, this idea of an interdisciplinary team taking care of the patient is great. We've all struggled with how do you get everyone engaged. And, of course, the idea of having everyone physically present on the nursing unit and rounding with the physician, doesn't really happen. I wish it did. Part of the issue is all of these people are trying to handle different issues at the same time. And one of the things that we found in trying to get our physicians on board was they didn't really understand how a DRG was even assigned. I laughed that I could create a novel, How Doctors Think We Come Up with a Working DRG. In meeting with different leadership positions within the hospital, I have found that that is something they're not learning in school, so it is up to us at the facilities to make sure that they have the information they need. So one of the things I like to ask physicians as I meet with them is, do you know how we come up with a working DRG? Some of the answers I've heard is the DRG is chosen by what condition is put first on the discharge diagnosis list. I've also heard what our focus of care was after admission. So two big things that I found that we had to talk to the physicians about to be able to get them on board was to have an understanding of what we're trying to accomplish. So I recommend that you make sure your physicians know that the condition has to be present on admission. If the condition wasn't present in the ER or there were not signs or symptoms that would lead you to think that that condition was present, it can't be the primary diagnosis. We do also look at the focus of care after careful study. Sometimes you just don't know what's going on with the patient in the ER, and as you get CT scans and results things back, you can actually establish that that condition was present on admission and use that as your primary DRG. We had a recent case where the physicians were surprised at how the patient was coded and billed, so I thought I would share that example with you. We had a 53-year-old male that was admitted with new onset of rapid AFib. In the emergency department, he was alert and oriented ×3. They started him on anticoagulation and cardizem for the rapid rate. They spent the next 3 days treating his atrial fibrillation. On day 3, the patient suffered a severe stroke and spends weeks inpatient. He actually spent 10 days in neurotrauma ICU. He was very sick. Most patients would assume that the stroke would be billed as the primary diagnosis in physicians. However, it cannot be related to coding guidelines. The stroke and stroke symptoms were not present on admission and cannot be captured as the primary diagnosis. Most of the physicians that worked on that case were very surprised that the stroke would not be the primary diagnosis and that this would not fall into a stroke DRG, because they felt that the focus of care was based on the stroke, and we were able to capture it as a secondary diagnosis. But as you all are aware, it cannot be the primary diagnosis because it was not present on admission in the emergency department. So that leads me to our next slide and polling question. Let's talk about your physician engagement. Ms. Katie, you want to take over?
Absolutely. So for the next polling question, the question reads, what is your physician engagement like today? Please select one of the following 5 answers and hit the Submit button at the bottom of the polling window. Again, you may have to scroll down to view the 5th answer and the Submit button. The options are healthy, a true care team approach, non-existent, unpredictable, automated, or both C and D. Again, please select one of the following 5 answers. Healthy, a true care team approach, non-existent, unpredictable, automated, or both C and D. We're going to give it a moment to wait for answers to come in, and then I'll turn it back over to Angie to comment on the results. Okay, Angie, back to you.
All right. Unpredictable. I can relate with that. Healthy, a true care team approach. That's impressive, 29%. And then some of C and D, unpredictable and automated. Okay. That's not surprising to me. Physician education is always a challenge. And then, of course, the engagement piece comes with that as well. As I mentioned before, I felt like that was part of the issue. The physicians didn't really understand what we were trying to accomplish. So one of the things that we first had to do was to provide the physicians with the why. We chose to do that here at CoxHealth with using some of their real examples from queries that we had sent. As you all know, when you send a query, you leave the physician options of other explanation. One of the things that we decided to do for the physicians that were choosing other explanation was to place in parentheses, please provide. We're willing to accept your other explanation, but please let us know what that is. One of the great things that I like about the JADA data and the platform that we're using with the Nuance tool is I have reporting capabilities for physicians related to their queries. So a lot of times what I hear when I go to a meeting is they're answering the queries, they understand what we're trying to accomplish. But then often when I look at my monthly report, I can determine, Houston, we have a problem. That allows me to be able to go to the physician leaderships with data to support when we're having issues with the queries. I can look at it as the provider as a whole, provider group as a whole, individual providers. It also gives me information on the type of query, so was it for the primary diagnosis, an MCC or CC, the documentation nurse that sent it, and then the physician response. Not only what did he say, but how long did it take him to say it. This has been a big piece of what we've been trying to utilize to assist us with some of the changes since ICD-10. As I mentioned earlier, we do have a tertiary facility. It is a newer program. We didn't start it until 2014. We do have some locum physicians that practice in that facility as well, so it has been more of a challenge. So I thought I would talk to you guys for a couple of minutes about ICD-10 and the physician education. One of the things that really assisted me in trying to focus on which physicians were having issues with the changes in ICD-10 were the reports and the agreement rate on the queries. As a department, the CDI nurses at CoxHealth decided to put the focus on ICD-10 on any PDX that was coming out unspecified. As you all know, part of ICD-10 was trying to get more specificity from the physicians, so that was one of our big focuses after October 1. The second, which also relates to ICD-10, is we increased the queries for the infectious organism. As you find, even with pneumonia or UTI, they want to know, what is the physician treating? One of the things that happened post-ICD-10 is we saw a 15% decrease in the physician agreement rate at our facility at Cox Branson. When I ran the reports and attempted to drill down, what I found was they weren't disagreeing. They were saying that they were unable to determine. So then I decided maybe they need more information about what it is that I'm trying to get from them. We do have a work group where we look at coding and quality initiatives. We meet on a monthly basis. It does include the CMOs from both facilities, quality, and coding. We've used that platform with the CMO support to present examples and CDI education at the hospitalist section meetings. Part of the issue we found with the unable to determine answers was the physician didn't understand what we were trying to get documented in the medical record. For example, was the condition present on admission? Was the condition a hospital-acquired condition? And when it comes to infectious sources, they can tell us that it's suspected, probable, etc. One of the biggest issues that we were seeing was for them to tell us what they suspected they were treating as far as an infectious source. Even when cultures are negative, the physician can still provide you with that additional information about what they think they're treating. So the program today at CoxHealth. The Springfield team was established in 2011. As I said earlier, it is the main facility. There are 500 beds. We have 9 full-time CDIs that review all primary DRG payers. They're looking at an average of 1,250 reviews per month. And we do also do the 48-hour follow-up on all of our cases. The query response rate is 99%. They respond. The agreement rate here in Springfield as well is greater than 80%. The CMI average in Springfield had a baseline of 1.71 in 2011, and the average is now 1.92. The embedded CDI product did allow us to review more charts. What I'm seeing here in Springfield is about 70 a month. We started the embedded program in February of 2015, so it's been over a year now. I think the staff are getting comfortable with it, and we may see that number increase more. The Branson team, as I spoke earlier, is the newer program. It was established in 2014. It is a 100-bed facility. I have 2 full-time CDIs there. Same process, we're reviewing all primary DRG payers. That's an average of 340 reviews per month there. Again, query response rate's great, 99%. The agreement rate is lower there. Again, I think that's related to the age of the program. We see it somewhere between 70 and 80%. The Medicare CMI was a baseline of 1.42. It's now increased to 1.60. We were also able to increase the number of reviews in Branson, and again, I think it's related to not having to log in and out of those 2 programs. It does help the CDI staff move quicker between cases. We did see a decreased agreement rate in Springfield as well, post-ICD-10. From October to about December, my agreement rate was basing 80%. However, my January 2016 number has me back to an agreement rate of 92% at my Springfield facility. And I think a lot of that is the providers here know our queries, they know what we're trying to accomplish, and they're familiar with the process. Whereas in Branson, it's just a newer program. All right. I think the true benefits of this program are coming from the embedded workflow. The product is 100% electronic, and it resides within the medical record. This has been a work satisfaction thing for the CDI nurses. They're no longer having to flip between the worksheet and the clinical notes or log in and out of 2 different programs to be able to do that. The working DRG is also visible to physicians while the patient is still inpatient. Now at this point, that doesn't always get their attention, but I think in the future as we look at bundle payments and different things, we'll see that become more of a focus for all physicians. We do have 100% electronic medical record here at CoxHealth. And the third thing, as I mentioned too earlier, is the DRG grouper. What an awesome thing to have. It provides an additional layer of information that really assists in communication with the coding staff. That's where I'd say the biggest benefit comes from having the grouper. We used to try to speak in ICD-9 or ICD-10 codes. We were communicating with the coder post-discharge to say, this is what we thought the primary diagnosis is, but again, we were using ICD-9 codes, and the coder was trying to talk to us about what they had final coded, and they were using DRGs, so this has really helped us to be on the same page as the coders. The other thing that's really nice about this grouper is it automatically prioritizes the surgical hierarchy. So you put your PCS codes in, and it decides which one should be running the DRG. We used to have the surgical hierarchy on paper, and we had to figure out which of the 2 procedures done would run the DRG, so that's been really nice. Increased visibility of that working DRG. The biggest group that is appreciating our working DRG being in the medical record at this point is case management. And the reason being, CoxHealth is participating in bundled payment initiatives. We participate in pneumonia, CHF, AMI, and we just started participating in elective hip and knee replacements. As we started the bundle payment initiative, one of the things that we found was nobody was telling us what the primary diagnosis they thought should be during the patient's stay. The only way they were finding out that information was through the working DRG of the CDI nurses. I don't know about your facility, but one of the things our facility that happens is the admit reasons are generally taken from the patient, and you would find funny things on the patient inquiry like chest pain, shortness of breath. So those things were not helping us figure out who was supposed to be in what bundle. Of course, with bundle payment, there are some things that you have to do for the patients. One is they need to get a letter of participation that they are in the bundle payment before they leave the facility. The other, there's a quicker follow-up, post-discharge, and different parts of the bundle where we needed to be able to track these patients. So now the case management department is getting a report of our working DRGs that fall within the bundle so they can make sure that they're able to see them and get them what they need prior to discharge. The embedded query template is another thing that's been a great satisfier for staff. The query is generated from their worksheet. The query itself is easier to create as there are clinical elements embedded, such as the date, a 24-hour reminder that goes to the CDI nurse as well as the physician. The communication can be with the coder as well as the provider in one system. Once we send the query, the coder can see it. Ability to copy and paste clinical references into the query. That was something that was important for us when we went to the embedded product. We had some facility standards, such as acute respiratory failure, that we were copying and pasting into our standalone queries. That is not something that we wanted to lose, so we were very happy to see that we can still cut and paste into this embedded query template. As a matter of fact, one of our latest quality improvement initiatives is we created a query template that we are still going to cut and paste into this provided area so that the providers are still getting queries that look the same and have that consistency. That was one thing that we did lose when we went to the electronic query that we are now trying to pull back in. The reports, again, as the manager of the CDI program, it's probably my favorite part. The robust reporting tools from JADA is something that we've always liked to use at the facility. It's part of the way that we measure the success of the program. The reports are easy to access. They are within the embedded CDI product. There are so many reports, I actually haven't even ran all of them. You have the ability to drill down to individual responses as well as physician groups. So for instance, you could look at one physician or the entire orthopedic section. I do have a continued access to the CDI nurses, their productivity, their impact, as well as the entire team or facility. Now that is one thing I did. I kept the Springfield facility and the Branson facility separate as far as reporting goes. The biggest reason was because of the history of the program. One was well established where the other was newer, and I wanted to be able to keep that information separate. The data ball is now generated within the program for those of you that are familiar with JADA data. I think the biggest ones are reports that I'm using, of course, is the case mix index. Those clarification provider reports is so helpful, I can't even tell you. Reimbursement impact reports, general. Like I said, there's all kinds of stuff you can get reports on. You can also schedule reports to be ran monthly and different things if you want to try and trend something. The biggest takeaway for the CDI staff was satisfaction. Increased satisfaction, access to additional information. They're using one system now. They don't have to wait on logging on to multiple systems. And I believe that we are now having increased knowledge related to the details of the DRG. including relative weight, length of stay, and the MDC. My next project is going to be length of stay. Wish me well. I do have a reference slide for you. The information came from the data. And now we are going to move on to questions. Miss Katie, you want to tell them how to do that?
Absolutely. Thank you so much, Angie. This does bring us to the Q&A portion of the program. So we would now like to invite you all to ask live questions of our speaker. To submit a question, click on the Q&A widget at the bottom of your screen. It may be open already and appear on the left side of your screen. Please note that your questions will remain anonymous and will not be viewable by other audience members. Our first question is, you mentioned that your query response rate was 99% at both facilities. Can you explain a little bit more about how you achieved this, and were those done using a telephone, in person?
Great question. And that is a common one, too, because queries are such a big piece of what we do being CDI nurses. Our CDIs submit those electronically. The response rate, initially here in Springfield back in 2011 when they started the program, the physicians were getting a bonus related to response rates and completion of their HIM records. Those things are no longer being done, but those physicians that participated with that have continued the process of making sure their medical records are done in a timely fashion and getting to the queries. We really actually have a great response rate, which I was glad to see. The response rate, however, I caution you, is only part of it. The other piece that you have to look at is, are they just quickly trying to answer the query to get something off their list of things to do, or are they truly taking the time to answer the query as it should be? So I caution you, just the 99% response rate doesn't really tell the full story. But yes, that's how we were able to accomplish it here.
Perfect. Our next question is, do any of your CDI specialists work remotely? And if so, is their response rate lower or higher?
Oh, well, you'll have to come listen to me next year. We just started a hybrid program here. We just started it in March, where the staff is doing 2 days of review at home and 2 days here in the office. So we're alternating who's in the office and who's at home. We're also having the CDI specialist attend section meetings. So regardless of whether it's their day at home or review, they're each assigned to a particular section. They're responsible to attend those meetings and take any information that's pertinent to those groups. So that's how we're handling it. But it's a brand new thing, so I look forward to presenting it next year with success in query response. I don't expect to have any decreased response rate because we do so much electronically now, and the physicians are really used to it being done that way.
Great. Our next question, is the main focus of your program the working DRG? Are there any severity or ROI? And do the CIDers take over the CSI coding, or do they start fresh? The coders take over the CSI coding, or do they start fresh?
The coders start fresh. They do and are required to look at our working DRG. One of the biggest challenges is making sure that they don't send a query that we've already sent. So that's a big reason why. The CDI nurses, of course, are not focusing on that complete capture of all the charges either. I really want them to focus on the primary diagnosis, getting the specificity of it, those MCCs and CCs. Assigning the DRG, I would not say is our primary focus. However, it has become a focus of the facility, which has given us a little bit more impact than what we had before. I think people knew that we were doing a working DRG while the patient was still here, but nobody realized what significance that could have to the entire interdisciplinary team. So that's why I made such a big deal of that. It's really been something that CDI has been able to show their worth and sit at those meetings and provide additional information about why that working DRG matters so much, not just for monetarily, but for quality. One of the other things that helps with physicians is when we're looking at their queries and they're unable to determine, I can show them this diagnosis that you couldn't determine can affect payment like this. It can also affect the severity of illness of your patient and therefore make you look like a better provider. So I really am trying to use all of those things as an educational effort. So yeah, great question.
Perfect. And our next question is, a lot of facilities are realizing that CDI specialists with a coding background are needed. Do you only hire RNs as CDI specialists, or are you open to those with a coding background that have CCDS or clinical documentation experience?
That is such an interesting question. It came up recently with a consultant that was here that was actually a coder that had her CCDS. We had a great visit with her. She's very knowledgeable. But our program is it is all RNs. 7 of the 11 RNs have their CCDS, so they're very committed to the program. A lot of them have been long-term CCDSs. I think the reason that our program works so well is partially because we do report to HIM, and the coders and us are on a team together. I've heard from a lot of programs that the coders and nurses kind of are against each other and not exactly on the same page, but that's one of the beauties of what we have. We can send questions to coders when we're seeing something while the patient's still inpatient that's not clear. They can send information to us post-discharge when they're trying to figure out why did we think they had a particular MCC or something. So I think that is a really great benefit to have. The nurses have to have that advanced coding information, and I really think it helps the coders to have somebody with the clinical background to be able to assist them with the things that seem to be gray, and there's a lot of gray in the medical record.
Perfect, thanks. And the next question is a question that we've gotten actually a couple of times. Do your CDI specialists work on the floor, or do they work from offices, and how do they communicate with physicians on a day-to-day basis?
The day-to-day communication is mostly done electronically, and that's how our physicians wanted it. They like email, particularly the hospitalist group. They're here in the hospital all day anyway. They're used to answering those electronic queries. I think we do have some providers that will reach out to the CDI and say, I'm not sure what you're trying to accomplish here, and they may have a conversation, but again, that can be done by phone or email. Some of the nurses work on the units. Some of them work in the office. I have some of them working at home. Part of that is due to the lack of space we have on the clinical nursing units to have a CDI sit full-time. So it kind of does depend on the nursing unit staffing and availability for a CDI to sit and get her reviews done. But most communication at this point is done electronically.
Perfect. And kind of connecting to that question, we have someone who asked, we currently use paper queries within the EMR. Do you have any suggestions on a process for this?
Well, the problem with the paper queries, and I remember them, because at this time I was a young cardiovascular nurse on the floor, and my physicians would take their query out. It was purple, so it would stick out. And they would crumble it up in a nice little ball and throw it in the trash can. So that's why I would recommend trying to get away from a paper query, because it's just too easy for them to try to manipulate the system and not address the queries. I would suggest trying to get something electronic, whether it be something through email or one of these wonderful programs.
Great. And you kind of touched on this during your presentation, but what percentage of records have queries, and do you do retrospective queries?
We do not do retrospective queries. We draw the line at discharge. What was the other part of that question?
Sure. What percentage of your records would you say you have to query the physician for more detail?
That is something that comes in the data, so I can tell you particularly what my last numbers were. Generally, it looks like we're asking a clarification that would impact a case, so we're either adding an MCC or a CC or getting more specificity of the diagnosis. It looks like about 20% of the time, so 20% of the cases are going to have queries that are impacting. And the severity clarification rate, it really depends. It has just been all over the place in the last 12 months, and I think part of that is related to ICD-10. It looks like there I have about a 30% inquiry rate for severity. So I'm still asking those severity of illness questions, even though it's not showing a true impact in the DRG. I know that was a question someone had earlier. We do still work on severity issues as well.
Great. And another interesting question that we had come in, how often does your organization practice verbal queries, and do you have a process for making a verbal query a part of the permanent medical record?
We do not do verbal queries. If I have a conversation with a physician about something that I need him to document, and then he documents it, I would only attempt to take credit if I had already sent a query. So for example, I sent a query to the physician for acute respiratory failure. He didn't understand what I was asking him. We had a conversation in the hallway about the acute respiratory failure, and he decided that the patient met parameters and he was going to add it to his note that day. In that type of scenario, I would go ahead and answer the query, making a note that the physician answered it on such and such date in his progress note, and then I would save it in that fashion. So I'm not a big fan of verbal queries. Again, part of it is we all have to show our worth, and part of what the CDI staff is responsible for is showing how many cases they reviewed and the impact they made on those. So I would discourage you from using verbal and try to make sure that you are somehow capturing the work that your staff is doing to impact that DRG.
Perfect. And another question kind of along those same lines, talking about queries becoming a permanent part of the medical record.
Yeah.
Do your electronic queries become a permanent part of your medical record currently?
They do. Mm-hmm. Every query we send. And when it becomes the permanent part is when it's answered by the physician. So we send it to his message center with all those lovely options, unable to determine another explanation. He answers it from there, and when he answers it, it saves to the medical record. We did have to include a comment at the bottom that says this is a permanent part of the medical record, but that was more for insurance trying to deny the information that was included in the query. Good question, though.
And are there any repercussions for providers that do not reply to queries, or do you have to remind your physicians to answer queries?
We do have, and that's one of the things that's in the software. There's a built-in reminder at 72 hours. So they get a 24-hour reminder, hey, you still have this query not answered. And then they get another one at 72. Since we work with the coding department, I have to say I'm so blessed that I have coding support staff that helps me once the query is not answered. So if we have a patient that's discharged and we still have a query pending, we actually have what we call a deficiency process here, where the coding support staff will follow up with the physician in trying to get him to answer the query as timely as possible. If the physician that hasn't answered the query is a surgeon, we have a process for them for deficiency as well. I think it holds a little more teeth for them. They're not able to schedule any elective procedures if they have unanswered coding or CDI queries pending. So that's one thing that the facility has done to try to assist us. But yes, we have coding support that follows up on that. So the CDI nurses, they are really handing the cases off within 24 hours of discharge. Even some that don't have a discharge summary, I've encouraged them to get to coding just because we want to keep that ball rolling. We want to get the bills out the door, and we don't want to be holding things up for CDI. So we are handing off to coding at time of discharge.
Great. And the next question is a question we've actually gotten multiple times as well. How many reviews are done per day, and do your CDI specialists work weekends or holidays?
That's a good question, too. So per day, they work 10-hour shifts. Per day, I would say that we probably cover 100 to 120 new cases. I told you we reviewed them every 48 after they come in. What was the other part of the question?
If your CDI specialists work weekends or holidays to complete.
Okay, so that was a great question. We historically have not done weekends and holidays. But one of the things that came up with bundle patients, bundle payment patients. We had some patients that were participating in some of those bundle payments that were coming in on Friday and then leaving on Sunday. So we had a little bit of a bucket of patients that were not getting a working DRG, and the care coordinators particularly were having a hard time knowing who was going to fall into the bundle or not. So I gathered some data about number of patients that were coming in and out during those times, and I found that there actually was a significant amount of traditional Medicare patients coming in on Friday and leaving on Monday or Sunday. So one of the things that we just initiated, and we started it in January, was a weekend option nurse. I do have a nurse that is working 3 12-hour shifts, Friday, Saturday, and Sunday. Her focus is on those traditional Medicare patients for the entire Springfield campus. So I do have that. I just started it, so I can't give you much feedback about it. I have seen our Medicare review percentage come up just in the short amount of time that she started. We do not cover holidays, and I don't think that part will change. But I do think we may have an increased need to get weekend cases done because they're just not staying as long as they used to either.
Great. We'll have to follow up with you and see how this weekend CDI.
Yeah, I have quite a few things pending that are interesting. One is that work from home trial, and this other is weekend option. So it's kind of a new day for CDI.
Definitely. Okay, well, moving on to our next question. Do you have physician advisors or champions that participate solely for CDI as part of an escalation process or to help with education?
I have a physician advisor. She is a hospitalist here in Springfield, and she does assist me with all of those things you just mentioned. She has been to formal training as well, just this past year. She is a great addition to have to the team because she truly can talk to the physicians as a peer-to-peer. I don't know if others have struggled with, when a nurse talks to a physician about something he needs to do, sometimes it's considered condescending or like we're trying to tell them what to do, and we really are just trying to help make sure there's a complete medical record. One of the things I've found is some providers have a better understanding of what we're trying to accomplish when they are talked to by Dr. France rather than one of the CDI nurses. The other thing that she's been able to do for us is to provide education related to different things we've struggled with as far as diagnoses that aren't specific. One of the things that Dr. France did for me this past year was she spoke with the surgeons related to some of their complications that were being coded. And she actually had very good feedback from the surgeons, wanting to know more from her, wanting to know if she could sit with them and look over an H&P and, try to show them what it is that we need them to pull out. So I do believe that the physician advisor role is very important, particularly when trying to work, physician to physician. That peer-to-peer, it does seem to make a difference.
Great. And as a quick follow-up to that question, is your physician advisor, is this a paid position or is it simply a volunteer position where they're volunteering their time?
It's a paid position, but she has to keep track of her hours and submit them to us because she does work full-time as a hospitalist. And that would be one thing I would like to see in the future, to have her have more time dedicated to CDI and education and physician training, and maybe take away some of her patient care time, because right now she's trying to do both, and I guarantee you that's a lot of hours.
Great. And as far as kind of going along with physician education, which strategies have you noticed work best for your facility, one-on-one or by attending physician staff meetings to educate physicians one-on-one? And like, how do you really build a collaborative relationship between CDI and the physician staff?
Well, I think most of it has to start with administration, letting the physicians know that what we're trying to accomplish is important, and that we really are trying to help them. I think that once you get across those two barriers, you'll have much better success and buy-in. What I have found to be helpful is to go to the section meetings with section issues. And that way you're truly not calling out one or two providers. You're not trying to make someone feel like, they're not up to par with their peers. You're talking about documentation issues, for example, related to orthopedics. So orthopedic section, here's the things that I'm seeing in your documentation that we're often querying for, or this particular diagnosis, it seems like always comes up unspecified. So what can we do to get more specificity? I would say that is going to be your key to success with physician buy-in. It's having those CDI members available when the physicians have time to think and discuss their documentation. And I found that that's simply not the case most days when they're trying to see patients on the nursing unit. I find more success in trying to do it either one-on-one, by phone, by email, or by section meeting. I would say any of those things work. Prior to ICD-10, the other thing we did is we did do some peer-to-peer education for the physicians related to the changes they were going to see in ICD-10.
Great. And as a follow-up to that question as well, what do you mean by section meetings? Could you describe what that entails?
So, for example, we have different sections: orthopedics, cardiology, oncology. So what I have is I have CDI nurses that review the cases in those areas. And so, for example, I have one nurse that looks at most of the oncology cases. She also covers the med-surg unit. So every month when they have the oncology meeting, she's going to attend as a resource, as a person, as a whatever they need in that section meeting. Now, one month she may go and sit there and nobody may talk to her. The next month she may go and have two physicians that come up to her and say, I was asked a question and I just don't understand it. The other thing, of course, if we're pushing anything out educational or any kind of system change, it's a great place to take handouts and those sort of things. So that's what I mean by section, and that's how we handle our assignments here.
Great. And kind of talking about assignments, how are your CDI specialists assigned patients? Is this by floor, by physician?
We do it by floor, yep. I tried lots of different things, and we've tossed lots of different ideas around, but we don't rotate. We do cover each other's work for vacation and those things, so everybody is expected to have a knowledge base of everything we do here at CoxHealth. However, we have found that the nurses as well as the physician staff are very comfortable when it is a person they're familiar with asking them a query. So, for example, the CD surgeons have a nurse they work with. When she asks them a question, they know if they don't understand, they can go find her a particular day on the nursing unit or email her. She'll explain it to them. It works very well. We've contemplated having them float or having a task queue or these kind of different things, but I think when you're looking at the big picture of what CDI is trying to accomplish, having a set person in a set area with a set skill set is not a bad idea. So that's how we're doing it.
Great. And have you seen the next question, have you seen an increase in PCS queries since October 1st? And if so,
oh my gosh, yeah.
Queries are you seeing the most frequently?
Orthopedic.
This is obviously something a lot of programs are struggling with.
Yeah, absolutely. It's orthopedics. And one of the things that was related to the type of device they're putting in is it's synthetic plastic metal. Well, of course, that was not information they were putting in their op note. They're saying Stryker 31/52, which doesn't tell me anything. When I look it up in the Stryker book, I find that it can be plastic, metal, or so that wasn't helpful. So this would be a good example. I went to the orthopedic section meeting, and I said, in order to code these cases in ICD-10, I have to know not only what you're putting in, but what it's made of. And they were all like, what? We've never charted that, la da da. So we're trying to come up with an electronic solution where the nurse can pull the product and the product description will go into the operative note. But until we get that solution, I went to the orthopedic section meeting and I said, this is what we're going to have to do. If you don't put it in your note, we're going to have to query you every time for what was the device made of and did you use cement or not. And, of course, they weren't real happy with it. But they understood because I went to them as a whole and said, this is something we're going to have to do and be able to code your charts correctly with the change in ICD-10, and so this is what I need from you. Are they always happy when I send them a query asking them that? No. But they're getting used to it, and they're now putting some of that information in their notes. So that's how we handle that.
Great. And the next question, are you currently doing anything with ambulatory or outpatient CDI?
No. I've been looking, I've been reading. I think that we eventually will. It's funny, the director of cardiovascular services has actually asked us about it. So I know it's something that's out there and a lot of different places are looking at doing, and I wouldn't be surprised if we didn't go there, but at this point we are not making any plans to do that.
Great. And are your CDI specialists participating in any PSI reviews?
No. No, we have quality nurses that do the PSI reviews on the back end. So one of the things we do try to do is to look for any of those PSIs as we are reviewing the chart and trying to establish if they were present on admission or not. We're trying to get some of that information from them as we do the concurrent review. But no, at this point we are not reviewing PSIs.
Great. And do you have query templates to avoid leading queries?
We have query templates that we use, and that was part of this embedded product is it has a query basis. But one of the things that we struggled with was the physicians, they're so funny. If they didn't look the same, they became confused about what is this, who's sending me that. So we really wanted to make sure that we got back to the template. So I really am pushing the template again with the statement about what's going on with the patient. Here's your clinical indicators. Here's your options of things that I'm asking you. And then, please provide your best judgment. And remember, this is part of the permanent medical record. So.
Great. And it looks like we have time for one more question. So last question. When you speak of initiating embedded software for the CDI program within your EMR, was there any pushback, and how did this process originally occur?
There was no pushback. Okay, so we had a standalone guide product. So we used J.A. Thomas. But what we were doing is we were using it as its own program. So you really needed two computer screens, one to have the program up, the other to have your medical record up, and then you were having to go back and forth among the medical record in that fashion. Whereas now, the CDI worksheet is actually in the medical record. It's part of the tabs, so I can just tab and go to it. It makes it much easier to back and forth between the different documents I'm looking for in the medical record. The standalone product was good, but I knew that it was becoming older. And so when I looked at what electronic software was out there, I wanted to stay with J.A. Thomas because I like their data. That's what they call it. I like it. And I really wanted that grouper. So that I kind of, true story, I went to the Cerner conference And I told Nuance that I wanted to be the beta site test for their trial, so that's how we got it. Don't be afraid to put yourself out there.
Wonderful. Thank you so much for answering all of these questions, Angie.
Oh, thank you guys for submitting them. I appreciate that.
No, absolutely. Unfortunately, we have run out of time for questions, and I just have a few quick closing remarks. In closing, we want you to know that your feedback is very important to us. At the conclusion of the program, a link for the evaluation will appear in the slide window, and it can also be found in the program evaluation widget at the bottom of your screen. We would greatly appreciate your thoughts on our program today. And just as a reminder again, this program does offer CCDS credits, but for the live program only. To obtain the credits, please download the instructions from the resource list widget. Once again, I'd like to thank our speaker for joining us today and sharing their knowledge on this topic. And to our listeners, thank you all for putting aside so much valuable time to watch our program. We hope you found it informative. For further information on this topic, please visit www.cerner.com and www.nuance.com. We look forward to providing you with other helpful programs in the future. Ladies and gentlemen, this concludes our program. Thank you again for joining us, and have a wonderful day.